Hi, I'd like to welcome everybody to the next virtual roundtable in the Pandemic Histories series. Today, we have three presenters talking about the history of vaccination, vaccine viewpoints from polio to pandemic influenza. I'm going to introduce the three speakers in the order that they'll be presenting. Dr. Chris Rutty is a professional medical historian with expertise in the history of public health, infectious diseases, and biotechnology in Canada. He's currently lead historian for the Defining Moments Canada Insulin 2021 National Digital Commemoration Project. Dr. Ruddy also holds an adjunct professor appointment at University of Toronto's Dalla Lana School of Public Health. Catherine Carstairs is a professor of history at the University of Guelph, and her research includes the history of drug legislation and addiction, the history of dentistry and Medicare policy, and the history of 20th century Canadian public health advocacy. Her most recent book with Bethany Philpott and Sarah Wilmshurst is called Be Wise, Be Healthy, Morality and Citizenship in Canadian Public Health Campaigns. Our final speaker will be Heather MacDougall, who's an associate professor at the University of Waterloo. She specializes in Canadian history and the history of medicine, public health, and health policy. She's the author of Activists and Advocates, Toronto's Health Department, 1883 to 1983, and has published extensively on the history of public health responses to SARS and H1N1. Her most recent research addresses vaccine hesitancy, especially to the MMR vaccine. So I'm going to turn it over now to Dr. Ruddy to begin his presentation. Dr. Ruddy, would you like to start your slides?
Okay, you seeing me? I turned on my camera. Okay. Oh, hang on. All right, are you seeing me okay? Elsa? Okay.
Yes, we can see you just fine. Go
okay.
ahead.
Okay. All right. Okay. Thank you very much. And it's been great. It's great to be involved with this seminar, webinar. What I'd like to do in this presentation, what the presentation I'm going to give you here is a kind of a quick run through of emergency responses, Canada's vaccine legacy, influenza, polio, and COVID-19 vaccines. So, all right. So after more than 6 months of a global pandemic, and with no end in sight, great hopes and resources are being invested in a variety of potential COVID-19 vaccine candidates. From a Canadian historical perspective, the COVID-19 pandemic experience resonates closely with the 1918 influenza pandemic, but it also resonates with the major polio epidemics of the early 1950s. In terms of mounting an emergency response, though, the development, production, and distribution of vaccines, Canada has a distinctive legacy. This legacy is most evident during the influenza pandemics in 1918, 1957, in 1976, although that was an abortive pandemic, and in 2009. And this legacy is also evident in the essential role that Canada played in expediting the development, production, and distribution of polio vaccines. So I'd like to highlight these Canadian emergency vaccine responses and how they can be related to the potential COVID-19 vaccines. So let's go back 100 years or so. This is a kind of familiar image here that serves as a nice backdrop here for a few slides. So during the 1918 Spanish influenza pandemic, about a sixth of the Canadian population, mostly young adults, was attacked by the flu, leading to some 50,000 deaths. With little understanding of the viral cause of the disease, the influenza virus wasn't really first isolated until 1933, there was very little that could be done to prevent, control, or treat influenza, or Spanish flu, if you want to describe it as. Nevertheless, early in this, the devastating second wave of the pandemic, Connaught Laboratories, which is part of the University of Toronto from 1914 to 72, and it's Sanofi Pasteur Canada today, in October 1918, launched a heroic effort to prepare a vaccine based on the prevailing view that Bacillus influenza was causing the disease. Connaught was soon able to distribute vaccine in large quantities, free of charge to provincial health departments, hospital, medical, and nursing staff, the military, and other public health services across Canada. And this work was focused on the basement of the old medical building, original medical building at the University of Toronto campus, which was built in 1903, and existed till the 1968 or so, or mid-60s. And that's where Connaught's antitoxin lab was based at the time. Due to this unprecedented emergency, no claims for the effectiveness of the vaccine were actually made, but it did no apparent harm, and the lab's efforts were widely appreciated. And actually, there's a vial of the actual vaccine that survived. It's in the collection of the Canada Science and Technology Museum in Ottawa, so, which is kind of interesting. At some point, we're hoping to do a little test of what's in there, actually. Connaught's vaccine was supplemented by a supply prepared by the Ontario Provincial Board of Health Laboratories. And also there were other influenza vaccine production initiatives elsewhere in Canada, most notably in Winnipeg and in Kingston. A similar desperation today for a COVID-19 vaccine. But in 1918, few effective vaccines actually existed beyond smallpox vaccine, and preparation efforts were quite localized and unregulated. And there's a link here to the Defining Moments Canada website, which actually Elsa just mentioned in my introduction. I did an article about the 1918 Canadian flu vaccine initiative. So you can follow that link and you'll see that article. So moving ahead a bit. So in the late 1920s, as smallpox faded and there was significant progress in preventing diphtheria, which was an effort led by Connaught Labs as well, the opposite was happening with poliomyelitis in Canada. And the COVID-19 story most closely echoes the Canadian experience with polio epidemics. So here we have a sort of profile of polio incidence in Canada. It's kind of drawn from my PhD thesis. That's kind of a useful look at how polio evolved, the epidemics developed over the 1927 to 62 period. So polio virus can damage motor neurons in the spinal cord, causing varying degrees of muscle weakness or paralysis. Particular chest muscle weakness could impair breathing, requiring iron lung support. That was kind of the most severe impact of polio. And polio disease variability is a common feature with COVID-19. So like no two cases of polio were alike, and it looks similar with COVID-19. There's a lot of variability in COVID as well. Between the 1920s and 50s, polio epidemics and polio outbreaks and epidemics relentlessly increased until polio vaccines were widely available. So for unique epidemiological reasons, the middle class was particularly vulnerable. And we could discuss that. There's a whole reasons behind that, but it's quite interesting. However, during the polio epidemic era, much remained mysterious and misunderstood about the crippler. So moving forward to 1947-48, Dr. Andrew J. Rhodes, a leading virologist specializing in polio, was recruited from the United Kingdom to lead a comprehensive research program at Connaught Medical Research Laboratories to investigate the virology, epidemiology, and clinical diagnosis of polio. Rhodes' research was funded by the National Foundation for Infantile Paralysis, the U.S. March of Dimes, which was spearheaded or founded in part by President Roosevelt, who had polio himself. Canadian life insurance companies, and newly established federal public health research grants. Fueled by substantial March of Dimes funds, a series of key discoveries accelerated progress towards a possible polio vaccine. Including in 1949, a Boston research team discovered a method to cultivate poliovirus in tissue cultures. Now, this was a major step and led to the Nobel Prize for this group. Also at the same time, in 1949, Connaught Labs research team developed medium 199, which was the first synthetic tissue culture medium, originally developed for nutritional studies of cancer cells. In 1951, a Rhodes polio research team at Connaught discovered that medium 199 could be used to cultivate the poliovirus in monkey kidney cells. So that was a key thing, connecting the original medium 199 work with the polio work. In 1951, Dr. Jonas Salk, who's based at the University of Pittsburgh, showed a formaldehyde inactivated polio vaccine could prevent polio in monkeys. But he used a traditional animal serum-based medium that would be unsafe for a human vaccine. But still, in the lab context, it seemed to be working. In 1952, Salk learned of medium 199 and asked for some, and it enabled him to, for the first human use of polio vaccine. It was a successful test, but only on a lab scale. In 1952-53, Connaught biochemist Dr. Leonie Farrell, pictured here on the right, she developed the Toronto method for large-scale poliovirus cultivation. It built on some earlier work she did with pertussis vaccine production. It's kind of a liquid culture, deep culture, large bottle rocking machine idea. And in July 1953, Connaught began to prepare poliovirus fluids for an unprecedented vaccine field trial. However, all this was happening just as Canada's worst polio epidemic year was just starting. So from Manitoba West, especially, every province felt the full effects of epidemic polio at record or near record levels. And prior to COVID-19, polio was actually Canada's last epidemic national emergency. I mean, we've had a few things since then, but the whole polio experience in '53 really kind of stands apart from other things we've had since. Manitoba faced the worst crisis in the country, if not in the history of the disease. So a few numbers here give you a sense of the impact. In many ways, the challenges associated with securing sufficient supplies of ventilators to manage COVID-19 patients very closely echoes the 1953 polio epidemic crisis and the urgent demand for iron lungs in many parts of the country. In '53-54, while the polio emergency worsened, Connaught undertook, as Salk described it, the Herculean task of producing over 3,000 liters of poliovirus fluids for what would be the largest vaccine field trial ever attempted. The poliovirus fluids were shipped to 2 US pharmaceutical firms for inactivation and processing into the finished vaccine. So sent down in a big bottle like this. On April 24th, 1954, the field trial began with 1,800,000 polio pioneer children, sort of grade 2-3 age or so. They were enrolled across 44 states in the US. Also, we were kids from Alberta, Manitoba, and Halifax later joined the trial. For this triple-blind field trial, the children received either the vaccine, a placebo of medium 199, or were observed. Meanwhile, Connaught prepared the full vaccine while the federal and provincial governments planned an all-Canadian observed control trial that would start in April 1955, regardless of the US results. So on April 12, 1955, the field trial, there was unprecedented media attention to the announcement of the field trial results. The vaccine proved to be 60 to 90% effective against the 3 antigenic types of the poliovirus. The vaccine was immediately licensed in the US and Canada. And in Canada, the Salk vaccine was distributed through a special federal provincial free program for children and subjected to further study of its effectiveness. Now, I'll give you kind of the quick version of the story. There's much more to it. There's articles written, I wrote for the University of Toronto Connaught Fund, a series on history of Connaught Labs. And you can follow that link and you'll look at articles 7 and 8. You can explore that story in more detail. Flashing forward a bit, a few years, 1956-57, a new pandemic strain of influenza virus quickly spread from Asia, prompting the first pandemic since 1918 and high global demand for an influenza vaccine. By this time, influenza vaccines have been developed on a small scale during World War II, and they were used in that context. Not too much beyond that, though, at that time. Improved influenza vaccine production progress enabled larger but still limited supplies in the face of sudden high public demand. The main limiting factor was sourcing the large numbers of eggs necessary to grow the virus. By the summer of 1957, concerned about the limited availability of the vaccine, the Canadian government called Connaught with an urgent request for 500,000 doses to be used on a priority basis to protect armed forces and the health services personnel. There was some vaccine was being made in different parts of the world, but it wasn't available in Canada, or wasn't available to be imported into Canada at that time. The Institute of Microbiology at the University of Montreal was also asked to contribute to the urgent request for vaccine. The Institute of Microbiology at the University of Montreal was kind of like Connaught, a smaller scale, but it was a similar kind of idea, producing vaccines, but mostly for the Quebec market. By July 1957, Connaught did not routinely, but at that time, Connaught was actually not really routinely making influenza vaccine, but it quickly assembled a team that normally prepared veterinary vaccines to cultivate the Asia 57 virus in large numbers of specially secured fertile hen's eggs. And after producing some 10,000 doses per week, the first vaccine was delivered to the provinces by early October. So moving ahead to 1976, February 1976, a new strain of influenza A virus, popularly referred to as swine flu, caused an outbreak among 273 of the 1,321 new Army recruits at Fort Dix in New Jersey, and there was one death. But there were fears that this strain, isolated from the fatal case, was related to the one responsible for the 1918 pandemic, and that the young and middle-aged had little to no immunity. So in March 1976, taking advantage of a unique opportunity to mount a preemptive strike, President Gerald Ford committed the US government to an unprecedented plan to immunize every American citizen against swine flu before November. In Canada, Federal Health Minister Marc Lalonde followed suit and approved an expedited swine flu immunization program, ordering 12 million shots, primarily for the chronically ill and people over 65 years of age. Connaught was asked to provide vaccine, but limited time and equipment led to a plan to import vaccine in concentrated bulk form from vaccine companies in Europe and Australia. And then Connaught would process, test, and fill it. But this time, Connaught had been sold by the University of Toronto, that took place in 1972, to the Canada Development Corporation, and it was now Connaught Laboratories Limited. Fortunately, the swine flu emergency did not materialize, but this unprecedented mass vaccination initiative encountered numerous obstacles on both sides of the border, including production delays, securing liability insurance for the vaccine producers, public resistance, and rare but disturbing adverse reactions. In the end, out of the 10 million doses that were ultimately available in Canada, only about 800,000 people received the vaccine. Okay. Flash forward to 2009. So while the pandemic threat of swine flu did not materialize in 76, the H1N1 strain of swine flu very much did materialize globally in 2009 and had a significant impact in Canada. So in Canada, there were over 10,000 confirmed cases and 428 deaths during the pandemic. As in previous pandemics, a major focus of public health, political, and popular attention was on expediting the production and distribution of a vaccine before the worst effects of the pandemic hit. In this case, timing was everything. So the first confirmed H1N1 case in Canada was reported on April 24th. First confirmed death was on May 8th. And on June 10th, the WHO declared an H1N1 a pandemic. On May 27th, the H1N1 virus seed strain was provided to GSK Canada to begin vaccine production at its facility in Quebec. Under the Canadian Pandemic Plan, GSK was granted the full contract to supply pandemic influenza vaccine. By July, initial vaccine production was slowed by low yields, pushing first vaccine delivery to September or October. On August 6th, Health Canada formally places an order for 50.4 million doses at a total cost of $400 million, split between the provincial and federal governments 60-40, or 60-40, federal 60%, 40% provinces. The delays coupled with continuing spread of the pandemic raised public expectations and many questions about the vaccine's safety and effectiveness once given, especially if the pandemic had passed by then. On October 21st, Health Canada approved GSK's vaccine just as the second wave of cases hit. On October 26th, the first immunization clinics opened across Canada, and it was actually the largest immunization effort in Canadian history, at least to that point. However, on October 27th, the sudden death in Toronto of an otherwise healthy as can be 13-year-old boy due to H1N1 galvanized media and public attention to the threat of H1N1 and sharply boosted vaccine uptake. Ultimately, only 40% of Canadians received the H1N1 vaccine, although it was one of the highest uptakes in the world. Actually, Canada was one of the few countries to actually launch a program like this on a national scale to provide the vaccine. So, the unprecedented effort also highlighted many issues, particularly related to the pandemic vaccine supply in Canada and the issue of vaccine hesitancy, especially among young adults. So, to wrap up, I just wanted to highlight a few of the legacy of Canada's emergency vaccine responses. So, the influenza 1918 story, its broad willingness to be bold in the face of a pandemic emergency and limited knowledge. So they didn't really hesitate. I mean, they did what they could with what they knew, and didn't really hesitate too much. 1957 flu pandemic. There was federal leadership to secure a vaccine, yet there was limited capacity to produce it quickly. And in 76, it was heightened US-Canadian cross-border sensitivity surrounding potential pandemic threat and rapid large-scale vaccine response. In 2009, a strong Canadian vaccine initiative was complicated by slow production and rollout that enabled public hesitations to grow. And with polio vaccine, the Canadian story of the development in the early 50s, highlights a strong and bold legacy of innovation and collaboration in vaccine development that actually persists to this day in Canada. But however, also persistent are limits in vaccine production capacity and efficiencies to meet the emergency challenges surrounding providing a potential COVID-19 vaccine or vaccine. Thank you.
Thanks very much, Chris. It's really, there was lots in that overview that I either never knew or had forgotten. Catherine, we'd invite you to go next.
Great. So I'm really interested in this question of, if we get a vaccine, are people going to take it or not? And there's been some really interesting poll data that's come out. A poll in Germany found that only 1 in 2 Germans would get vaccinated if a vaccine for COVID-19 became available. A YouGov and Yahoo News poll in the United States had similar results, with 55% of Americans saying that they would be vaccinated if a vaccine became available. Here in Canada, things look a little bit more optimistic on the vaccine uptake front. A poll released by the Association of Canadian Studies on June 14th indicated that 68% of Canadians would get vaccinated, 15.6% said that they would not get vaccinated, and the remainder were unsure as to whether they would not, or whether they would or they wouldn't. And in this poll, interestingly, there was a correlation between willingness to be vaccinated and the level of trust that people had in public health officials. And I'll get back to that at the end of my short talk. I've been very interested in this question of why people support or do not support public health measures for a long time. In the book that I recently authored with Bethany Philpott and Sarah Wilmshurst, Be Wise, Be Healthy, we looked at the early campaigns for diphtheria toxoid in the city of Toronto, as well as National Immunization Week, which ran from 1943 to 1971. The campaign against diphtheria was an enormous success, as Heather has also shown in her work on the Toronto Public Health Department. Diphtheria was a really frightening disease. Children fell ill very quickly. A membrane formed in their throat that could lead to suffocation and death. Until 1930, 1 in every 7 or 8 children in Canada got diphtheria, and it was the leading cause of death for children between the ages of 2 and 14. And so a vaccine against diphtheria first became available in 1925, and the City of Toronto began making it available to children free of charge the following year. In 1931, the Toronto Diphtheria Committee was established to promote the vaccine. It was hugely successful in all but eradicating the disease. Deaths from diphtheria in Toronto tumbled from a few dozen a year in the early 1930s to none by the late 1940s. The campaign was not the only reason for Toronto's success with diphtheria. As the historian Jane Lewis has shown, there was also a ready supply of the vaccine in Ontario. Canadian physicians were very positively disposed towards its use, and the Ontario Board of Health played a major role as well. But the campaign, I think, did make a difference. During Toxoid Week, Torontonians were bombarded with information. TTC streetcars had advertising cards telling people to get the toxoid. Billboards highlighted the importance of getting children vaccinated. City Hall was decked with a banner. Newspapers featured daily tallies of the number of children who had been vaccinated. There were lectures, there were short trailers before movies, there were radio announcements, and the Canadian Social Hygiene Council even got the churches on board, and so the exhortation to have your children vaccinated was even delivered from the city pulpits. School scribblers had pro-toxoid messages, and teachers were encouraged to provide daily lessons on diphtheria. There is also a very detailed pamphlet available with a surprising amount of information. I think the level of detail is important here for reasons that I will get into more later. At the Times, the publicity put forward by the Diphtheria Committee could be very shaming. One radio talk, for example, said, if your children die of diphtheria, it is your fault because you choose not to take the trouble to protect them. Another asked, is your child toxoided? If not, it scolded, he is a definite menace to himself and to other children. But the publicity campaign appeared to make a difference. The campaign ran in the month of April, and doctors reported that far more parents sought out the vaccine in April, May, and June than they did in other months of the year. National Immunization Week, which was another project of the Health League of Canada, built on the success of Toxoid Week. And I forgot to show you some of the materials that were used in Toxoid Week. By the time National Immunization Week launched in 1943, there were more vaccines to protect against childhood illnesses. A vaccine against whooping cough was introduced in Canada in 1936, 37, and by 1943, it was available in combination with diphtheria toxoid. In 1947, tetanus was added, and the DPT vaccine became the agent of choice in most provinces. Polio, of course, was added to the list in the mid-1950s. National Immunization Week drew on the same tools that had made Toxoid Week such a success. Women's magazines ran editorials and advertisements. Radio stations ran spot announcements. The week was promoted on billboards, window displays, streetcars. It was promoted on family allowance checks. Doctors' offices would do promotions, as would laboratories and insurance companies. There were catchy slogans, often different every year, like be wise, immunize. They deliberately frightened parents, much like the Toxoid campaign, by convincing them that disease threatened everywhere. So in this advertisement, for example, it says, if your child has not been immunized, he is an easy mark for the diseases that lurk around every corner. They also continued to scold parents, as in this advertisement, yes, you have a very sick baby, and that baby should have been protected by immunization. The advertisements, I have no more slides, so the advertisements told parents that they should listen to the guidance of experts and defer to the advice of doctors. This apparently played reasonably well in the immediate post-war era, a time period John C. Burnham has described as the golden age of medicine. It might play less well today. As Elena Conis describes in her book, Vaccination, beginning in the 1970s, the women's health movement and the natural health movement did much to convince parents that they needed to become well-informed advocates for their own health and that they needed to do their own research. So they should no longer just listen to the experts, they needed to investigate it on their own. Doctors themselves, of course, became more aware of past medical errors and adopted a more patient-centered approach. The hectoring, self-assured tone assumed by the Health League of Canada would undoubtedly backfire today. At the same time, it does seem that the well-funded publicity campaign did help to improve childhood vaccination rates and significantly reduce the mortality from infectious disease. So I want to return to the question of the possible uptake of a COVID-19 vaccine by talking about the public health issue that I've written about most extensively, water fluoridation. Water fluoridation is fascinating because, unlike most public health issues, it frequently came to a vote. And more often than not, people voted against water fluoridation. Now, water fluoridation is definitely a very different issue from vaccination. For one, although we know that oral health is really important to overall health, it lacks the same sort of urgency. People very rarely die from an infectious tooth. So, infectious disease seems to, has a much greater resonance in society. Secondly, one of the problems with water fluoridation is there's very few possibilities for exemption. So we're all reliant on the public water supply unless, of course, we choose to drink bottled water. But at the same time, I think these debates that took place over water fluoridation and continue to take place can tell us a lot about how people respond to the messaging of public health. One of the conclusions that I drew from my examination of water fluoridation debates across the country is that detailed information matters. The pro-fluoridation community often provided very simple, easy to understand messaging about how fluoride reduced tooth decay. This probably had its purpose, but for segments of the population that were more suspicious, the anti-fluoridationists provided in some respects far more detailed information. They had long pamphlets backed up with citations. So to some degree, it appeared more scientific than the information that was being provided on the pro side. So I think skeptical members of the public are going to want to decide for themselves. During this pandemic, there's been much bemusement at the do-it-yourself epidemiologists out there. But I think that there is a real hunger for information, and science communicators and public health officials will need to provide people with detailed and accurate information about why they should take the vaccine and the possible risks and benefits. Work by my colleague at the University of Guelph, Maya Goldenberg, on vaccine hesitancy suggests that people are not skeptical about science, but they are skeptical about the institutions of our society. And so we've already seen that some of the opposition to a possible COVID-19 vaccine has to do with Bill Gates' involvement. There is considerable distrust of big pharma and an awareness that a COVID-19 vaccine could potentially be very profitable for whoever develops it. Vaccine uptake is likely to be much higher, I think, if governments are transparent about who is behind the vaccine and who is likely to profit from it. And I also think they're going to need to be very honest about what the risks and the benefits of the vaccine might be. So I'll leave it at that.
Thanks very much. I'm sure that we're going to end up cycling back around some of these questions as a group. So I'd like to invite Heather to give the last presentation, and then we'll have some interpanel discussion.
Okay. Well, Catherine and Chris have given me a wonderful foundation for my totally oral presentation on pandemic messaging during the novel H1N1 outbreak of 2009. And my focus fundamentally is a statement that Andre Picard made. This is the health writer for the Globe and Mail, in one of his numerous wonderful articles during that pandemic, when he, in fact, I think became one of the dominant media voices. And that was that the public health officials, by and large, had failed markedly in conveying uncertainty with clarity. And to pick up on what Catherine said about Maya's work on vaccine hesitancy, risk communication is a huge challenge for anyone who undertakes it. It requires conviction on the part of the person presenting the information. They must be consistent, and certainly, as we've seen with COVID-19, do we wear masks? No, not at the beginning. Now we're mandating masks. This is driving the public around the bend. But I think another point that Catherine made at the close of her comments, crucially, that wasn't as effectively created during 2009 as it should have been, was transparency. Because Canada did. It had, as a result of SARS, created the Public Health Agency of Canada, appointed its first chief medical officer, and in theory, it had a pandemic plan. But as we have seen in 2020, the plan may exist. Everyone is supposed to know what they're supposed to be doing, but whether or not it actually functions the way it was intended is, of course, very much a result of circumstances and federal-provincial relations. What is striking in contrast between 2009 and the present is, of course, the extent of federal-provincial cooperation, and the fact that, in contrast to 2009, our current Prime Minister, Justin Trudeau, is a very clear voice responding to the issue. Stephen Harper believed that you should separate federal and provincial activities in health, and to a certain extent, I would argue, hung his Minister of Health, Leona Aglukkaq, and his Chief Medical Officer, David Butler-Jones, out to dry. So what did they do in terms of messaging? They were constrained because the Harper government required all messaging to go through the Prime Minister's office to meat and potatoes, very generic messaging about washing your hands, coughing into your sleeve, sanitizing objects that you touch, and above all, please don't touch your face. And when in doubt, contact the Public Health Agency for your brochure, have your own personal pandemic plan. So provinces and health units also developed their own pamphlets, advertisements, educational campaigns, but they had to get the testing going and, of course, at the provincial level, ensure that the curative services continue to function. So the media, both old, newspapers, TV and radio, and new, the internet, jumped onto the story. And I, in my research, ran across numerous articles saying, is there too much emphasis on what's happening in Mexico, in the United States? And of course, we're getting blow by blow in each province and each city as cases emerge. But looking actually at the way that the legacy media, newspapers handled it, it was quite striking that they did have health reporters, they did provide scientific information, and they interviewed researchers, experts, public health officials to create question and answer articles, which I think actually were highly educational and pick up on the point that Catherine was making about the need to keep the public informed. The stories gradually shifted to a recognition that there was a lack of transparency, that David Butler-Jones was fundamentally saying, we're doing our best. We are having, yes, problems getting this vaccine manufactured, but we are doing our best, and when it's ready, it will be good. That did not sit well with a segment of the population, and you start getting what amounts to citizen science in many of the leading papers, as women in particular write in about their experience being pregnant, because pregnant women were regarded as one of the very high-risk groups. Other stories of individuals who suffered and had horrific experiences with it in the 20 to 45 age bracket remind me very much of the YouTube videos that we're seeing of people in similar age brackets today. The point of all of this was to criticize the apparent lack of federal action and the lack of planning, the lack of clarity about what kind of vaccine, an adjuvanted or unadjuvanted vaccine, was going to be available, when it was going to be available, and who the high-risk categories to receive it first were going to be. Fundamentally, I think where they failed, and Picard points this out numerous times, is that if they had simply explained that vaccine production, as Chris pointed out, is not necessarily a totally effective process, and that GSK was told suddenly in the midst of producing its vaccine that it had to do an unadjuvanted one for women who were less than 20 weeks pregnant, as opposed to the women who were beyond that period, who could take the adjuvanted one that was for everybody else. And the feds did not, in fact, announce their list of high-risk first receivers of the vaccine until the middle of September. The outbreak begins in April. It starts to pick up steam, surprisingly somewhat, in the summer when kids at summer camp come down with it. And then, of course, when the children go back to school in the fall, it starts to increase. And as Chris pointed out, when that 13-year-old Brampton hockey player dies, it causes pandemonium and a huge surge in demand. So if we look at this, what we see is, as with 2020, a vaccine is regarded as the life-saving. And it's not just to save human lives, it's also very much to save the economy. So great attention is therefore focused on the surveys. At the beginning, 60% of Canadians were, yes, keen on taking the vaccine. By the fall, because it appeared to be less frightening and less of a killer than it had been, numbers had gone down drastically. The other thing that was going on, of course, too, was that this was the first time that the internet had been a big player. And Christy Blatchford wrote a wonderful article talking about weird vaccine opponents that she had read up on the web, and made the point that, of course, it's opinion. It has probably no scientific validity, but when experts tried to counteract it by being on the web themselves, they were regarded simply as one more opinion, not with the trust in expertise that Catherine and her students demonstrated resulted from the Health League and faith in science during the 1950s and 60s. So when you look at the lessons that I think that the current pandemic planners should be bearing in mind as they face the challenge of implementing vaccine campaigns, should we actually get a variety of different vaccines. First of all, they should remember that there has to be prioritization of first recipients. But that in contrast to 2009, when the various hockey teams and other people jumped the queue to get their immunization, this time they better stick with their high-risk groups, whether it's the people in frontline positions or specifically the immunocompromised. Secondly, they need to be upfront with us about vaccine production, the difficulties, the challenges, and, as Catherine pointed out, the risks. The other thing that happened in 2009, which I'm hoping will be less in evidence in 2021, was a lack of consistency among the provinces. Ontario, BC, and Quebec opted to do the seasonal vaccine first for the seniors, and then to move on to the H1N1, whereas New Brunswick and Manitoba and a variety of other provinces immediately just went to H1N1, assuming that there wasn't going to be a need for the seasonal vaccine. Broadcast across the country through the various media, obviously that created a drastic drop in confidence and lack of consistency. And then the final thing, which probably doesn't apply to 2020, is that this was a flu pandemic in 2009. And of course, although Ontario had been giving free flu shots to everyone who wanted them since 2001, most people basically saw flu as not a very dangerous disease. And so the relative mildness of the fall wave meant that flu skeptics said, no, I don't need it. And then, as I said, when the little boy died, that changed parents' minds. But as Chris pointed out, only 40% of Canadians actually got the vaccine. So when you look at messaging, it does go back to conviction, consistency, clarity, and transparency. And we will have to hope that as they roll out the immunization campaigns, those are the principles that are guiding their actions.
Great, thanks, Heather. I'm going to put my moderator hat on for a minute and pose the first question, I guess, that maybe we could start with taking a step back and looking at what the differences are historically speaking. And Catherine, you hinted at some of this, so maybe I'll start with you, and if others want, they can comment. What has changed over the course of the 20th century that creates these underlying problems now that are facing both public health and science when it comes to things like trust, and also the extent to which people actually are afraid of infectious diseases, or at least to the extent to which fear can motivate them. So what happens over that, say, since the end of the flu pandemic through to the present day in the broader historical context on some of the issues you were raising? Catherine, maybe I can start with you.
She's muted.
Unmute.
All right, thanks. Yeah, I mean, I think that, one of the things that it's important to keep in mind is that, we talk a lot about vaccine hesitancy, or, we see this very active anti-vaccine movement. And, certainly there's a community of people today, with a whole variety of beliefs, whether it's, the clearly misguided belief that vaccines cause autism, or sort of more general vaccine hesitancy, or concern that vaccines might be good for other children, but my child, doesn't have a good immune system, and so I worry about imposing this, or what, the parents see as a risk for that particular child. So, I mean, we pay a lot of attention to that right now, that particular debate. But actually, I mean, what's striking is that vaccination rates are really high overall. I mean, Canada doesn't have the immunization tracking system that we should have, but it's clear that, most people do actually get their children vaccinated. There are particular pockets where vaccine resistance is higher, and that's where we've seen some of the epidemics emerge. But to some degree, I feel like the importance of vaccine resistance has been sort of overemphasized because of the media culture in which we live in now, which I think, has just transformed everything, right? So how we get our news, how we get our information has changed so dramatically in the past 10 or 20 years that, that certainly posed new challenges for public health. But I also think it's allowed for the construction of certain kinds of debates which are happening out there that maybe aren't as debated as we think they are. There's these sort of very strong outspoken communities that I think, I mean, historians should never predict. But I mean, one of the things that I see now is that people's fear of COVID is very, very high. Right. And I think that's going to, I mean, maybe that'll change. It seems like, we're now merging in Canada, at least, into a stage where things feel safer. So maybe people's fear will dissipate depending on how long we stay in this phase 4. But I think that, the sort of idea that was tossed around that, well, people haven't seen the impact of epidemic disease. They haven't had children dying of scarlet fever and whooping cough and diphtheria. I think people are good and scared of COVID now. So that, I think, will make a big difference as well. Sorry, that was a very somewhat incoherent answer to your question.
No, I don't think it was incoherent, but maybe I'll let Heather weigh in on this. And then, Chris, I wanted to ask a slightly different question about other issues that might arise for vaccination, should we have a vaccine. But Heather, do you have any thoughts? Do you kind of agree with Catherine that it gets a lot of oxygen?
It does, I think, on 2 different levels. One of the things that I noticed in my research on measles, the Canadian Immunization Conference is held every second year. These conferences started in 1994, and I think it's either the 96 or the 98 conference. They're talking about how to message effectively to counteract the anti-vaccination group and maintain trust. And I started attending these in 2012. And what was really interesting was it was clear to me that beginning in 2010, there's a whole component within the public health movement that is really focused on vaccine hesitancy. And 2010 is actually amongst the first times that it's officially named, and the World Health Organization sets up an expert committee to look into it. And so it's become embedded in their thinking. And I think what worries them is not the sort of 2, max 5% of the population that's completely anti-vaccine, but the mushy middle, the people who are hesitant about specific vaccines, but not about all of them. And so they're trying to figure out how best to respond to what these needs are. And often it's very simple. They don't want their babies to cry when this happens. They don't want to think of their child in pain. Totally natural. And I think that then so they're one component keeping this whole thing alive, in part because it could have very severe long-term effects. Catherine's absolutely right. We don't have a national system, but on a province-to-province basis, we don't look too bad, but we aren't meeting the standards for immunization set by the scientific community. So that's a worry. What I do think, though, has happened is that the internet provided a platform for the anti-vaxxers and the libertarians that puts them on a par with public health experts and scientists. And that the problem is, how does the average layperson figure out what is legitimate science from the pseudoscience that appears on the anti-vax platforms? They are really, really good at pulling out the section of every public health or scientific report that says limitations. And of course, if you add that to the distrust of big pharma and the libertarian strain that says all government intervention is unacceptable, it's a very, very dangerous combination and a rabbit hole that many people could fall into.
There, I'm unmuted. Actually, I've been looking through the Q&As a little bit, and if you wouldn't mind, we could maybe shift to some of the questions. And there's one for Chris that I'd like to read. In terms of current vaccine development, what can we learn from ethical and safety review of other vaccines at the population trial levels? And here the question is, says, with Canadian work on Ebola, Canada delayed both phase 1 and phase 2 trials and wanted to distribute the scientifically and ethically invalidated vaccine in response to public and governmental pressure. So any thoughts on this kind of ethical and safety side, Chris, historically or in the present day?
Not sure exactly what to say, respond to that. Actually, does anybody else want to add to that? I'm not sure how to really respond to that specific question.
You want to think about it for a second?
Yeah.
If we can come back to it too.
Yeah.
Maybe let's think about a question about the role of the citizen scientist, because that was a phrase, I think it was Catherine that used that phrase, right? The role of the citizen scientist. So the second part of the question was, are there examples when the citizen scientist was a benefit that created not so much ambivalence or challenging, but actually created buy-in from the public? And in what circumstances would assist in that? So do we need to think of the citizen scientist as always a critic of public health discourse that isn't helpful? Or is there a way in which that kind of lay conversation can actually help?
Well, I was just going to say, I think a role that I've played and I think can help in all this is just the role of history itself. I mean, we're historians here talking about history. And my experience, I mean, I've done a lot of stuff online exhibits, all kinds of different things. And actually, I haven't had a lot of anti or vaccine hesitant I would sort of expect to get a lot of that, but I don't get much of it. Perhaps because from a historical point of view, there's not a lot to argue. I mean, there's less to argue when you actually lay out, how diphtheria in particular, was quite sharply declined after the toxoid came in the mid-20s and polio experience and so forth. And so that actually has a lot of weight, just and trying to personalize the experience of infectious diseases and the value of the vaccine and how it changed the situation quite dramatically in many cases. So, I mean, there's a generation that has grown up without much experience with infectious diseases, direct experience. I mean, the COVID situation is actually may change that on a much broader scale. Flu was different. I mean, H1N1 in 2009, people know what flu is and can easily discount it potentially, but COVID is a whole nother beast. But the point is, I think there is a role for history doing what we're doing right now to kind of engage the public on that level, to actually demonstrate how vaccines have worked, basically. They're not perfect, but they've worked very well. I mean, smallpox is eradicated, polio is almost eradicated. Diphtheria is non-existent, except that it would come back if we stop vaccinating. A lot of examples of that. And try to counteract, I suppose, some of that hesitancy with those sort of facts, I guess. Not so much the scientific sort of debate, but just the actual demonstration of how vaccines worked for a long time. And there's a lot of value in that, and engaging the citizen, on that level with them. And I've done that through a thing called the quarantine tent, and public engagement on the street, just with parents, and they respond. And you kind of personalize the experience of the diseases, and then answer questions and engage with them on that level. And it does work, actually.
Can I respond to that one as well? I think that, I saw it interestingly play out in the water fluoridation debates. So in the late 1960s and early 1970s in Montreal, there was, I think it continues to exist, an environmental group called STOP. And Carol Spindle-Farkas, who had a PhD in nutritional sciences, began getting interested in the question of whether or not there was too much fluoride in our system. So the total body burden of fluoride was too much. Because of course fluoride naturally exists in fish and tea and other foods. And so if you look at how much we're consuming from all the different sources, was it something that we needed to be concerned about? And she really prompted a more extensive look by the scientific community about the sort of body burden of fluoride. So, I do think there is a place for that citizen science that can intervene really effectively in some of these debates. And I think another place, right now it seems to me, it feels to me that the academic or research world is being transformed by community-based research practices. So more and more researchers are going out to communities to see what their concerns are, what they want us to research, and really seeing ourselves as servants of the community rather than as experts on high delivering knowledge. And I think, to my knowledge at least, this hasn't really played out in the vaccine research world. Heather, you'd know far more about this than I would. But is there a place, there were legitimate concerns about the diphtheria vaccine, for example, in the 1970s. So if, experts took those concerns seriously, and some of them did, right? Is there a way of sort of engaging with those communities and addressing their concerns and doing research that addresses their concerns in a way that would engage those populations and make them more willing to trust the experts, the institutions? The institutions, of course, need to be trustworthy. And I think engaging the public is one of the ways of doing that. So I think we do need to take the concerns that are raised by people who are opposed to public health measures. And, I see so much, my Facebook feed is filled with academics who are like, how can people be anti-vaccination? They're just stupid. And it's like, no, actually, people have really legitimate concerns. And I think it's beholden on us as researchers to take those concerns seriously and investigate them.
So before Heather jumps in, I just want to read one question that we've had about maybe splitting up that concept of the public, right? So into taking into account class, occupations, question, for example, crowded workplaces, racialized and indigenous communities, recent immigrant groups, and how, you know, people might have different perspectives on vaccination based on that. I don't know, Heather, if you have any thoughts on that.
Well, I do actually, Essel. One component, of course, that I didn't talk about was the huge mistake that Health Canada made right at the beginning of the H1N1 in sending body bags to a First Nations community in northern Manitoba, where, as the chief and the elders pointed out, that looked to them as if they were being told that they were getting no help whatsoever and that they should just expect to die. And death and burial practices were, of course, inherent in their culture, and body bags were not part of that culture. So that's one area where I think we have done slightly better in 2020, although my sense is that most Indigenous communities feel that it's far too late. And quite frankly, if you don't deal with the social determinants of health, COVID is just one more problem. It's not what's really at issue. Class and gender, of course, are huge. The migrant worker issue in Ontario is, quite frankly, appalling. And yet this is something that I found they knew about in 2009 because the outbreak began in Mexico. And so the migrant workers coming to Ontario in the spring of 2009 had to be tested before they were allowed to enter the country. So a lot of things are not new, but at least now we are discussing them. And this seems to me to be the point at which, yes, we can have much more input from the people who are experiencing this themselves. And I'm very impressed with the way the migrant workers are standing up and demanding better treatment than they have received up to this point. So we are indeed starting to see movement.
Can I add to that too, Essel? I mean, COVID is very clearly showing who has privilege in our society and who does not in terms of the populations that are being most affected. And I think, one of the things that I found troubling is, the past few weeks we've seen a lot of judgment cast at young people who are seen to be sort of frivolously out partying and getting COVID as a result. But what I see is that those are also the same people, by and large, who are working in grocery stores. So it's fine somehow for them to be putting themselves at risk as workers, but it's not fine for them to be at risk in their leisure time. So I think, class politics is writ large all over the COVID-19 epidemic. So it's an excellent point.
Mm-hmm. I have a question again, a specific question about polio, Chris. Can you unmute yourself, or do I have to do it? Hang on a second. I'm just trying to navigate my restrictions here. For some reason, this system likes to make me God and take away the right of the individual speakers to unmute themselves. So the question has to do with polio after the 1937 spike. And the question is there been any firm evidence proven as to the reason why polio numbers decreased in the years after 1937?
Decreased? Well, the general trend was upward. I mean, there was a lot of variation across Canada. Ontario was hard hit in 1937, as was Saskatchewan. There had been a sort of building from the late 20s, from BC, Alberta, Ontario, Quebec, and Manitoba through the early 30s, late 20s, early 30s, and it peaked majorly in 1937 in Ontario. There was a decline a bit A lot of with polio's growth was sort of demographically driven, and also ironically driven by our public health progress. I mean, as public health systems improved, sanitary systems improved, what was normally a endemic infection among very young infants that did nothing, was a gastrointestinal. It spread very effectively. It was endemic. That endemicity declined over time, and then leaving children to actually become exposed to it later on when their immune systems were less able to respond to it. So polio was kind of ironic in that sense. It was became worse as public health systems improved. And when you get to the post-war period, particularly the baby boom and large families, young parents in suburbs, that's what really fueled the major epidemics of the late 40s, early 50s. So it's sort of polio was sort of an anti-pandemic in a sense. It was the opposite in many ways to COVID, because almost everybody was exposed, but as people were less exposed, that's when you started getting epidemics. So if we didn't have a vaccine, it would have gotten going, really. So.
Well, it's 10 after 7, and I know that I am watching the number of participants slowly drifting down. So before I let everyone go, I want to share poster for our next event. For those of you who are interested in following the series, and exciting new developments for myself and Chris Colesso, who helps me do the organizing on this series, that we will now have Zoom registration. So you can register directly at Zoom using this link. So I will be posting this poster on the CSHM website, and CSHM will share it as it normally does through social media. And when you get it, you'll be allowed to directly register through Zoom, which is hugely, hugely exciting for me personally. You know, I really want to thank everyone for their ongoing support for this series. It's been super, super great. I think probably our next one following that won't happen until August, since it is summer and some people want to go on vacation. So thanks everyone. And thank you so much to the panelists. I really enjoyed all of your presentations. I've always been very interested in vaccine hesitancy and vaccine development, but have never actually done any research on it myself. So thanks very much. And thank you to everyone in the audience. And I'm sorry if we didn't get to any of your questions. Maybe feel free to reach out to the presenters if you'd like to talk further. Okay, thanks so much. Any last minute stuff, presenters? Okay.
A huge thank you to you, Essel, for organizing all of these. They've been terrific.
Yes, thank you very much.
Yes,
Thank you, guys. Stay safe.
You too.
Bye-bye.
Bye.
Bye.